the current two DNB residents in our reporters escorts are both from the city of Jhansi. So I'm sure that in times to come you will have greater expertise with the younger generation joining in. Now I'll be talking about chronic kidney disease, and when I joined nephrology in 30 years back, we just had one drug for chronic kidney disease, that was ACE inhibitors, and our cardiology friends used to joke that they used to call us ACE doctors. We took it as a compliment, and we used to tell them ACE means we are the best. But the honest was we didn't have much to offer to our patients. But I'll tell you, over the last especially decade, it has been a journey of learning, and I am reminded of this quote from late President Kalam's book Wings of Fire, that the illiterate of the future are not those who can't read or write, but those who cannot learn, unlearn and relearn. And we have had to unlearn some of the past concepts and relearn some new concepts in managing chronic kidney disease, and I'll show you how. But just a quick recapitulation that CKD means abnormalities of kidney structure and function for more than 3 months, which could be either of these. So albumin creatinine ratio more than 30 milligram per gram, markers of kidney damage 1 or more, which is either an ultrasound or a urine abnormality or a GFR of less than 60. So you have to confirm this over 2 periods, over a period of 3 months, 2 occasions. Now it is not a nephrologist problem alone. It is important for everyone. It is important for the surgeon because he needs to look at the perioperative renal dysfunction, NSAIDs, anesthetists, physicians, obstetricians, radiologists, intensivists, cardiologists. So making a diagnosis of chronic kidney disease is very important for an overall optimal outcome across a diverse range of specialties. So that's why I think even a physician has a very important role to play. I'll just share with you 2 or 3 index cases. Now this is a 44-year-old lady. She was a school teacher of Delhi Public School, Vasant Kunj. When she presented to us, I had joined Delhi at that time, Fortis Vasant Kunj, and she came to our emergency with accelerated hypertension, breathlessness. When we asked her, she did have severe hypertension way back in 2003. Nothing much was done other than some echo, ECG, atenolol, which is how usually hypertensives are managed most of the time. But this time when we evaluated her creatinine was 8.4. Contracted kidneys, and to her horror, she had stage 5 chronic kidney disease. We initiated on dialysis. Fortunately, the husband was willing to donate. 2007, please mark the year. So we are in 2025. She is 18 years post-transplant. She has now done her PhD, and she is she taught in a college in Agra, now retired, married her daughter. So look at how the management, her life has changed. But then that is not the goal. The goal is actually to slow progression of chronic kidney disease, add years to life, and this is, I'm sure these are patients you would be seeing much more commonly. A 50-year-old diabetic comes to you with diminution of vision, swelling of feet, hypertension, creatinine of 4.4, which translates into eGFR of just 22. So he's got diabetic kidney disease, so he could present to a surgeon, he could be coming for an angiography. So it requires optimization of medical management of chronic kidney disease. This is another consult that we saw on rounds, a 63-year-old diabetic for 9 years, 130 by 80, microalbuminuria was negative, creatinine 1.3, normal size kidneys, and our physician friend could not put a label on the edema, so he just asked me casually, does he have chronic kidney disease? And I'll come back to him later. But first of all, what are the kidney function tests to help us diagnose chronic kidney disease? And they are very simple, not expensive at all. First and foremost, a urine analysis. But the postgraduates are here, but this is a urine you should do yourself. So if on the first morning specimen, the specific gravity is 1010, that means the kidney is unable to concentrate the urine. You are dealing with a chronic kidney disease patient. Albuminuria again is a hallmark of chronic kidney disease. Urine sediment, a wealth of information. So urine for us is called uroscopy. It's perhaps the most important test, but also the most inadequately performed. So RBC casts, acute pyelonephritis, broad casts, and I'm sure you have seen most of the patients walk into your OPD with a lab report saying urine NAD, and let me tell you, the lab is being very honest about it. NAD means not adequately done, so you should do it yourself. Now, the next test is urine albumin quantification. And earlier on, we used to burden our patients with big cans, but now it has been shown that a spot albumin, the first morning specimen you do, the albumin creatinine ratio correlates very well with the 24 hours proteinuria. So no need of burdening the patient. But yes, obviously you have to reconfirm this on more than one occasion. Why? Because things like fever or the urine sample was given after a morning session at the gym or jogging, not uncommon, or even a UTI can cause transient proteinuria. That's why we say that do confirm it and also give proper instructions to these patients once you are doing this test, because a lot is going to be dependent on that. Now, when I was doing my post-graduation, we were told that urea and creatinine are the gold standard for chronic kidney disease. And this graph tells you that why this is no longer considered 24 karat gold. So this is the serum creatinine, and this, as you can see, the serum creatinine actually starts increasing. This is the GFR here, and this is the urea. So you track the GFR. The normal GFR is 100 to 120. So the GFR starts decreasing. So even at 70, your serum creatinine is normal. 60 is the first time the serum creatinine will show a tiny blip, and that also if you are lucky to have a good lab. And the urea actually rises much later on. So GFR below 40. So obviously this is not the way to diagnose kidney disease. And yes, we have made, and this is a very simple chart which tells you the perils of using the serum creatinine to guess the level of renal function. So no guesswork here. So serum creatinine of 1.3 in a 24-year-old man means eGFR more than 60, and more than 60 is not, it is safe to diagnose him as a normal person provided everything else is normal, which means no microalbuminuria, ultrasound is normal. So don't give him additional stress if it comes at 85 or so. But yes, if he has anything else, then he would qualify as kidney disease. But a 63-year-old man with the same serum creatinine has got GFR of 59. So you just confirm it once more over, say, next 1 month, and you don't need anything else to diagnose chronic kidney disease. And an 80-year-old lady, the serum creatinine is 1.3, which means eGFR of 42. And a lot of you must be thinking, very cumbersome, who's going to calculate the eGFR? It's very simple. Your paramedical person can be trained to do it, because now we have calculators on every phone. Just put it, download on your phone or on your desktop, and this information will be, all you need is the age and the serum creatinine and the gender obviously, and you will put now this is very important. So now this is how we stage chronic kidney disease: 1 to 5, 3 is A and B, A1 to A3, and this is also called the heat map. So if the GFR is more than 90, there is no microalbuminuria, these patients have low risk. So, and these patients should be managed predominantly by primary physicians. Obviously, confirmation by your nephrologist is important. Now, as the proteinuria increases, the risk is increasing. So, even here, in the same GFR, if you have proteinuria more than 300, he is a patient at high risk. So, that is why there are two things you have to look at. You have to look at eGFR, you have to look at proteinuria also. And this patient is going to land up, in stage 5 very fast as compared to this patient, the patients in this group. So look at eGFR, look at proteinuria, both. Now we'll come back to this patient, 63-year-old gentleman, which I saw in a consult. So we repeated it. This eGFR was again in the same range, and actually he had chronic kidney disease with a seemingly normal creatinine. And that actually alerted us to undertake a simple study. So we looked at 774 records of our preventive health checkup people. So there were people who had come to the hospital and gone back. Why were they getting health checkup? Because some of them, had employer insurance. Some of them did it just for, to get a checkup. And we found that when we did an eGFR estimation, 9.56%, nearly 10% had chronic kidney disease. So they had already gone back, had not seen us. So we obviously called them back, but this is what I'm trying to say is chronic kidney disease is a silent killer. And until you investigate, you'll not pick this up. And this is a landmark paper in Lancet 2008, very relevant today, telling us that there is an 83% higher mortality for all cause and 100% higher mortality for CVD, cardiac disease, in these patients who have chronic kidney disease. So these are the patients again who require attention of nephrologists as well as our cardiology friends also. But yes, we have to pick them up from the community. Now this is a study from Italy where they found that although the community prevalence of chronic kidney disease was 23%, a physician diagnosis was there in 3.9% only, because everybody was using serum creatinine. Again, this is 2011, and now obviously this is no longer true. Also, the blood pressure control in majority of these patients was far suboptimal. Now, if you have a diagnosis of chronic kidney disease, your blood pressure control has to be meticulous. The targets have to be less than 130/80. So this is an importance for the cardiologist. If you have chronic kidney disease, you can see the mortality rate increases. From EGFR more than 90, it's 4.1, but the moment it goes below 70, it's 20.5, and at 70 the serum creatinine will be normal. So 5-fold increase, and this is less than 70, more than 90, hazard ratio is 1.68. Again, published in JASN 2002, but still very relevant for us today as to why we should be screening these patients. Again, for the obstetrician, there is an accelerated deterioration of renal function in some patients with chronic kidney disease. The prognosis depends on the degree of renal dysfunction, and it is only if you have mild renal insufficiency, you should tell the obstetrician that the patient should go ahead with pregnancy. Otherwise, the risk is very high. Moderate renal insufficiency, 20% of pregnant patients will progress to end-stage kidney disease, and if there is severe renal insufficiency, 45% progress to end-stage renal disease. Not only that, the obstetric outcomes are very poor in these. So the baby is also not there, and the kidney function is worsened, and that's why very careful monitoring in the pre-conception clinics, as we call it, is important for obstetrician. So CKD should be remembered as C for check EGFR, K is for kick off a conversation with your patient, and D is for diagnose early, because this is a disease high prevalence and low diagnosis. As I said, community prevalence is now 15 to 20%. Now, when to refer to a nephrologist? Early stage, there's no doubt, stage 1, stage 2, stage 3, A, primary care physician should be the primary doctor, and nephrologist is there just to confirm a diagnosis. But 3B onwards, the nephrologist takes over, and the physician is always there for day-to-day monitoring. Now, what can primary care practitioners do? I think you can do a lot. First of all, recognize and treat at-risk patients. Educate patients about CKD and treatment. Manage blood pressure and diabetes. Address CVD risk factors, and also monitor EGFR and ACR, and encourage your labs to report, especially EGFR, not only just serum creatinine value. So you are the people who are going to pressurize. You are the first point of contact. The initial diagnosis is going to be established by you, and day-to-day blood pressure monitoring, sugar control, I think makes a lot of difference. Also evaluate anemia, refer to the dietitian if you are lucky to have one. Consider patient safety issues. Definitely nephrologist should be, as I showed you, a partner in your day-to-day management. And 3B onwards, definite nephrology referral earlier on, once at least, just to confirm, because otherwise the patient is going to run away to some baba. Now, this is an article which showed the impact of primary care CKD detection with the patient safety approach. So this is undetected CKD, patient may have had gout, taken NSAIDs, undergone contrast, treated inadvertently with aminoglycosides, just because nobody knows what the serum creatinine is, got diuretics, and progresses rapidly to end-stage kidney disease. A similar patient, who has got periodic evaluation of renal functions, will not be giving NSAIDs, will be very careful with contrast, will not be using aminoglycosides, will be very carefully using diuretics, and these patients have got much better preservation of kidney function. Now, the clinical approach. What therapy can offer, and actually a lot today. First and foremost is meticulous blood pressure control, 130/80 or even lower, 120/75 if you have proteinuria. Diabetics, again, good blood sugar control. Anti-proteinuric agents. So not only ACE or ARBs, SGLT2 inhibitors, we have now mineralocorticoid receptor antagonists, and we have GLP-1 receptor agonists, which are very useful agents, especially in diabetic kidney disease. MRAs have come now in also, besides diabetic kidney disease, non-diabetic kidney disease. Anemia earlier on only iron was given, but now erythropoietin came in, and now we have this class of drugs called HIF-PHI inhibitors. So you can give them orally, very patient friendly, and most important, they are not that temperature sensitive like erythropoietin. So even in especially the summer months, drugs like oxemia, there's an Indian drug also now called oxemia, which has been patented and marketed by Zydus. Bone disease, again, use phosphate binders because bone disease is easier to prevent, difficult to cure. BAT25, vitamin D analogs, cinacalcet, and lipids obviously are one of the primordial modes, essential parts of therapy. And this is what we call it the 4-pillar approach now for CKD. So ACE inhibitor, ARBs, SGLT2 inhibitors, non-steroidal MRAs, of which, as I said, but you have to be careful about hyperkalemia here, SGLT2 inhibitors, mycotic genital infections, ACE inhibitors, especially we are using in combination hyperkalemia remains an issue. And for diabetic patients, GLP-1 receptor agonists, again, nausea, diarrhea, are important issues. So these 4 pillars, the 4th one, exclusive, it is being evaluated in non-diabetic kidney disease, but so far only for diabetic kidney disease. The first 3 are now applicable for both diabetic, non-diabetic kidney disease. And this is a sub-analysis of the EMPA kidney trial, and what I found was that empagliflozin, very impressive, used may potentially delay end-stage kidney disease up to 27 years. So excellent value for money. So if you use it at 85 ml per minute GFR, 4,100 sessions of dialysis avoided. 23.1 years of extended kidney life. So even up till eGFR of 30, you are giving your patient 9 additional years, and you are saving him from 1,400 sessions of dialysis. And we are lucky in our country, generics are available, so it comes at a very throwaway cost. So again, just 4-pillar strategy. RAS blockers, they act at the afferent arteriole, they decrease hyperfiltration, endothelial dysfunction, also cardiac benefits are there, we know that. Then we have the SGLT2 inhibitors, which is the second pillar. Both of these target the hemodynamic pathway. They increase the afferent arteriole, improve tubuloglobular feedback, hyperfiltration, proteinuria, oxidative stress is inhibited, increase anti-inflammatory and they have anti-fibrotic effects. Also, finerenone, which is the mineralocorticoid receptor antagonist, this also decreases inflammation, fibrosis, endothelial dysfunction. Perhaps the only drug which targets the inflammatory pathway decreases proteinuria. That's why nephrologists, have got a fancy for this drug. And the 4th pillar, so far exclusively for diabetic kidney disease, reduces weight, dyslipidemia, oxidative stress, improves endothelial function, also improves proteinuria. Now, for chronic kidney disease stage 5, there are only 3 options: kidney transplantation, hemodialysis, or peritoneal dialysis. When to offer dialysis or transplantation? Definitely dialysis for all patients under 80 years who are on dialysis should be offered kidney transplantation. eGFR less than 10, you should offer preemptive kidney transplant. How do you compare both? Now this is very important. So this is dialysis, the first bar, then is disease donor transplant, and this is living related transplant. So 99% 1-year survival as compared to 77% 1-year survival with dialysis. So you are going to lose about 23 of your patients, 100 out of 100 patients at the end of 1 year. At the end of 5 years, only 33 will be alive in dialysis, but after kidney transplant, 77. And after 10 years, 11 will be alive on dialysis, and still 55 plus. So that is the difference. And the cost of kidney transplant is, it's about 5 lakhs or so, which is actually just equivalent to 1 year cost of dialysis. That's why kidney transplant should be the preferred mode of therapy. And now we can do ABO incompatible transplant, and I think this is a picture Dr.Sanjeev will remember. This was a patient from nearby Jhansi only. He used to run a small shop. He was on dialysis for 7 years and was actually finding it difficult to earn for himself. But his only problem, his blood group was O. Finally, his wife came forward, blood group was A, but titers were very high. The anti-A titers were 512. But we told him that you better take a chance. So we did a long period of plasmapheresis. He did post-transplant plasmapheresis. He is now 11 years post-transplant, just came about a couple of months back. absolutely normal kidney function, earning for himself, supporting his family also. So from a patient who was dependent for his survival on the family, he is now supporting his family. That's what transplantation does. So we can do transplants in HIV positive patients, we can do them in sensitized patients. So patients who have antibodies now, we have done steroid-free transplants to optimize growth in children. We can do paired kidney exchange. So if you have two families where the blood groups are not matching, are complementary, the law allows us to exchange blood groups. And I said, even if there's a previous transplant, and yesterday one patient came, Mr. Jain, again Dr. Sengel will remember, he was about 15 years after his second transplant. So he is doing well.
This is from Lalitpur.
Lalitpur, yes. So he's been following with him only. He came to me just for a courtesy call. So to conclude, early diagnosis of CKD is important. So screen high-risk patients. What are the high-risk patients? All hypertensive, diabetics, stone disease, heart disease, rheumatological diseases. Nephrology referral, a collaborative approach. Make the nephrologist confirm your diagnosis. Evaluate for reversible factors, infections, dehydration, high blood pressure. We have now very good agents to slow progression of chronic kidney disease. We can add years to life to years of these patients. And discuss options for renal replacement therapy in advance so they can prepare for kidney transplant, at least those who are willing to go for it, and we can do transplant across blood groups. Now this is still very important. Why it's important for you? Because when you go on the social media, this is what you find. People, there is a lot of alternative therapies, absolute crap which is being advertised by very leading, authoritative figures. We have patients coming to us after spending 5 lakhs on alternative therapy, which they have, would have got a kidney transplant. And this actually, stimulated me to launch my own YouTube channel. So you can use it give it as a source of information, as an authoritative therapy. We have put all information about chronic kidney disease, diet, options, the disadvantages of alternative therapies. There are about 250 videos. So this was some time back. Currently I have 42 lakh views, about 55,000 subscribers, just to give an authoritative alternative, because otherwise and all of you should be there on YouTube, because the YouTube is, it is crowded by all what you call quacks, because we are busy in our practice, but it's very important and in our day-to-day practice. And our work has been recognized by the former Vice President. And I end on this note by Robert Frost, that we have promises to keep and miles to go before we sleep, and miles to go before we sleep. And our team is there in this very city of Jhansi. Dr. Akash does a regular OPD here. I think he's there. Can you stand up, Akash? So he comes once a month. If you have any patients, who are willing, planned for kidney transplant, you can refer them. I think he comes at Chiranjeevi Hospital and also is in touch with Dr. Sankar. So this facility is available, and for post-transplant follow-up is also done in the same city. Thank you.
Thank you, sir. Thank you for clearing our thought.
Any recommendation for prednisone and
sir,
when to stop?
Yeah, when to stop. So I think prednisone is again a drug. Got cardiac benefits, you have got renal benefits. I stop this drug if the patient is getting into hyperkalemia. Otherwise, you should continue this drug, but do not start it under EGFR less than 20, because then the risk of hyperkalemia is higher, and benefit also in studies is not very clear beyond that, below 20. So there is I think it was a fine heart trial. They have shown some cardioprotective benefits even in advanced chronic kidney disease, but I am not using it below. But hyperkalemia is something you should monitor for when you are using these agents.
It is very effective in reducing proteinuria, I think so. Once the proteinuria comes into the range, then can we stop it?
No, it will bounce back. So we have done that before, it will bounce back. Because you are targeting due to the inflammatory and profibrotic pathway. Yeah. So there are 3 pathways I showed you. One is the hemodynamic pathway, the second is metabolic pathway, and this drug is unique, which targets, the only one which targets the profibrotic pathway, inhibits fibrosis. So do not stop this drug. I know it's an expensive drug, but you can tell the patient that it's going to save you many, many years of dialysis. So that is offset.
We have to constantly watch for hyperkalemia.
It happens generally in the first few weeks, but once a month, yes, you should.
Dose is 20 minutes.
Dose is, so if there is 20 milligram normal kidney function, but if the GFR is less than 60, only 10 milligram. Medicines have come that in stage 4 and stage 5 CKD, it can definitely delay dialysis. I think that's a good point.
Yeah, and there's another drug which is commonly used, acetylcysteine and taurine combination by the name of
again a very good question. First of all, this drug is available only in India. So you can understand, I won't say anything more than that. There is no scientific logic of using ecosprin or acetylcysteine. I have time and again. The biggest plus point of this drug is the name, Nephro-Save.
So, I mean, even when we don't prescribe, patients come back with, you know. So.
Yeah, they say that you have not written kidney medicine.
Yeah, and one more point I would like to highlight that in patients of CKD, role of adult vaccination plays a very important role.
Yes.
We have seen patients who get into these infections and they succumb to these infections.
Very true.
It's very
true.
important.
In India, infections remain, paramount. And at the earliest encounter, you should vaccinate these patients against pneumococcal, annual vaccination for influenza, and if the patient is more than 50 years of age, we also have now the herpes vaccination, and last but not the least is the hepatitis B vaccine. All these vaccinations should also be done.
Yeah. Sir, one more drug, Silvamber or Silvasure.
Sorry, sir?
So Silvamber or Silvasure, one more drug.
So Silvamber is there, that is in a broad class of phosphate binders. And if you are, you can use calcium carbonate, which is much more cheaper. But if you are getting into difficulty or hypercalcemia, or you are not able to control the phosphate despite calcium carbonate, then Silvamber can be used as a phosphate binder.
Role of calcium is there, sir. Role of calcium.
Calcium, sorry, Mura. Sorry.
In CKD.
So calcium, chronic kidney disease, first of all you have to remember, these patients are at very high risk of cardiovascular disease. And they have found very high calcific scores in the coronary vasculature. So the guidelines are very clear. They tell us do not use more than 1500 milligram per day of calcium. We use calcium as a phosphate binder. We are not interested in supplementing calcium in them. If they have hypocalcemia, then you look for vitamin D levels, or look for the parathyroid level. They might be having hyperparathyroidism. But predominantly, very few of them would be hypocalcemic per se, requiring calcium supplements. If that's what. But we are using calcium more for phosphate binders.
Which calcium?
Sir.
Is calcium?
Calcium carbonate is the best, because calcium carbonate binds very efficaciously to the range of calcium. But try not to use calcium citrate, because there the calcium absorption is very high.
So calcium acetate. What of calcium acetate? Which is better?
Calcium acetate is also very good. Yeah, carbonate acetate are almost equal here.
Sir, which antidiabetics? Excuse me, sir. What are the antidiabetic agents which should be requiring dose modification in patients with moderate estimated GFR?
Yeah. So first thing you should do if you see a patient of chronic kidney disease, a lot of them are on glimepiride. So get rid of the glimepiride. Metformin should be used. I think a lot of people are underusing metformin, and very elegant studies came initially from India by Dr. Mani from Chennai. And now it has been validated by all the leading associations that you can use metformin right up to an eGFR of 30. Only thing is dose is 500 milligram twice daily. Then among the gliptins, linagliptin stands apart because no dose modification is required. So we don't use. I keep it simple for the patient because certainly the GFR might decline. So use linagliptin rather than any other gliptins. Repaglinide is a very useful drug which can be used in advanced chronic kidney disease. And I mentioned already SGLT2 inhibitors actually should be used right at the time of diagnosis of diabetes. Right, that's what the guidelines are telling us.
So thank you for giving excellent talk in CKD.
Kindly felicitate and request Dr. Sanjeev to kindly felicitate our respected speaker. Give a big round of applause.
So I request